Welcome to the Ldn Radio Show, brought to you by the Ldn Research Trust. I'm your host, Linda Elseygood. I have an exciting lineup of guest speakers who are Ldn experts in their field. We will be discussing low-dose Naltrexone and its many uses in autoimmune diseases, cancers, etc. Thank you for joining us. This show is sponsored by specialists in gastroenterology who are located in St. Louis, Missouri, and they provide sensitive, reliable patient care. They diagnose and treat challenging GI problems. Dr. Leonard Weinstock researches extraintestinal disorders, including Restless Leg Syndrome, chronic pelvic pain, and rosacea. Visit www.gidoctor.net. Today I'm joined by Dr. Leonard Weinstock, who's a gastroenterologist from St. Louis in Missouri. Thank you for joining me today.
My pleasure. My pleasure.
First of all, I wanted to...
Linda, you're still saying St. Louis, but I'll give you that one.
Did I really? I meant to say St. Louis. I thought
yeah,
I
you
had.
Did.
Okay. So, first of all, could you tell us what made you the person and the doctor you are today? Did you always want to be a doctor as a little boy?
I actually thought that I was going to be pushed into that role because my uncle was a physician, my dad was an orthodontist, and my uncle was an MD, but he was a meat dealer. He was a kosher butcher. But besides that, everybody thought of me as being the caring guy and the guy to go to if you have problems and talk to. And I don't know, I think I was just promoted into this position. My older cousin, he became a doctor. So there was a long line of people in the professional fields, and I knew I was not the businessman. I just knew it. I could never see myself selling cars like half of my family did, and I truly, and I always cared for my grandparents, and my grandfather was blind, and I read to him from the newspaper, and it was always suggested that I should be a doctor. And of course, when you go to college, you're going to protest. So I decided, well, I'll think about being a veterinarian. So I played around with that idea. I worked on dairy farms for a couple of summers. And then one of the farms, there was a 5-year-old who had just undergone chemotherapy and radiation for a brain tumor. And you know, then I just saw that side of medicine from a personal side and was intrigued by it. And on the flip side of things, if the cow, you know, was ill and didn't produce, then they would sacrifice the cow because it wasn't worth keeping. So I was turned off to veterinary medicine, and so I was more interested in people. And so then I came back after that summer to college and decided, well, I'm going to do pre-med, but I'm going to do it my own way. So I did, I was interested in chemistry, organic chemistry, which led to interest in pharmacology. And at University of Vermont, you could create your own major, and so I did. So it was clinical pharmacology, and I worked in a pharmacology lab doing studies on antibiotics, and so I got into it in a way backwards, but it was a very forward way of thinking. I trained with an incredible scientist who was pretty tough on me, but I learned so much from him, who is a pharmacist. And I also learned that the lab is not where I was meant to be, just because it was kind of crazy. So I got into it backwards, but then I got to experience working with patients in med school and just got very excited about being a doctor. And all along I had, interesting ideas and schemes and ways of looking at life perhaps differently than other people. And so I always, I always was different, if you will. And so ultimately when I went into internship, in fact, I got into the idea that my irritable bowel patients, there was no good medicine. I should do what the Brits do and try hypnotherapy. So in clinic, I would actually do hypnosis on my patients with irritable bowel. And so once again, just anything new and different that could help my patients ultimately led me to the person I am.
So how did you find the hypnotherapy for irritable bowel?
Well, it was very interesting. My mom had been working with a guy who was doing self-hypnosis and teaching her, and I tried it on myself, and it was a good way to relax and pretty much like deep meditation, but you're trying to get to your subconscious. And some of my patients were helped, but it didn't help that, I was in this clinic with paper-thin walls and, people were talking next door. So it was a little tricky. But, forward ahead 30 years, I've been talking with a therapist who wants to set up hypnotherapy for irritable bowel syndrome in Nashville, and I've been giving her advice. So, there's value. I certainly do refer to a hypnotherapist and therapists that do EMDR work, rapid eye movement for stressful events that can play into many, many, many GI conditions. And so I've utilized that training to be aware and to make my patients have the best of both worlds, both pharmacology and emotional support.
So with irritable bowel, is it a case of trying to relax those muscles through hypnosis? What is it you're trying to aim to do?
So, yeah. Well, there's a brain-gut connection in irritable bowel, and no matter what cause of irritable bowel there is, stress does play a role in many cases, but not all. And I've always been interested in irritable bowel syndrome since I got into gastroenterology. And one of my first grand rounds that I had to give, I was going over irritable bowel and food sensitivities, and actually diagnosed myself with lactose intolerance, which nobody else had been able to do. So it was kind of funny, years of suffering, and then just preparing a talk led me to a good self-diagnosis that's helped me throughout the years. But irritable bowel, as I used to tell my patients, is probably 20 different things. It's just an umbrella term for many, many disorders that present the same. And then that's what got me started with syndromes. And in fact, when I went to med school, we learned the basics. And then like for half a day or less, we would touch on various syndromes. And I was thinking, well, here we are, theoretically, the smartest specialty, or theoretically, healers and so forth, and we're talking about syndromes and not diseases. And that really bugged me. So in my first 13 years of practice, after graduating my GI fellowship, I did both internal medicine and gastroenterology. And then when Katie Couric had her colonoscopy on TV, everybody wanted to have a colonoscopy, and I basically had to send 2,000 letters to internal medicine patients I was taking care of and saying, I'm just too busy to do both. And so in terms of, we talked a little bit about my interest in skin and restless leg syndrome and all sorts of things. It was because I was doing internal medicine for a long time, both 4 years of residency and then skipped 2 years of fellowship and then to 13 years of doing both internal medicine and gastroenterology.
Well, that's given you a good platform to work from, hasn't it?
Yeah, I mean, well-rounded. It's instead of being too focused, and that as people will hear when I talk about this new syndrome called POTS, will really show that if you have blinders on, if you're too focused, then you'll be like the parable of the 3 blind men and the elephant, who touch the elephant in different places, and one thinks it's a tree, and one thinks it's a snake, and so forth. If you don't have your eyes open to everything, then you're going to have trouble understanding the whole disease process or the whole syndrome, if you will.
Mm-hmm. I know that you're going to be talking about POTS at the Ldn conference in September. For those people that don't know what POTS is, could you explain that for us?
Absolutely. It stands for Postural Orthostatic Tachycardia Syndrome. So by itself, it's a condition where people stand up, their pulse goes rapidly up, they get dizzy, lightheaded. That's the cardiac part of it, but it causes many other conditions. So really the bottom line is that in many people with POTS, it's a autoimmune condition where the antibodies are stimulating different parts of the sympathetic nervous system. So that's the we have this flight or fright nervous system in our bodies, the sympathetics and the parasympathetics. And if we're being chased or attacked, then the sympathetics turn on, our pupils dilate so we can see better, our heart races so we can run faster, the sphincters contract so we don't have to go to the bathroom while we're running away from whoever's chasing us. In caveman days, it was a saber-toothed tiger. Now it's, many bad people, unfortunately. But the sympathetics, when they're totally unbalanced, we have terrible symptoms from the eyes, the head, the ears. There's ringing in the ears. There's vertigo. There's migraines because of constriction of the blood vessels. And there's many, many other symptoms, many gastrointestinal symptoms that, as if you've got blinders on, then you're dealing with people who have slow stomach emptying, and so you call them gastroparesis. But if you don't ask some questions, well, are you dizzy when you stand up? It's not usually one of the questions that gastroenterologists ask. Then you're going to miss the diagnosis. And then it also runs hand in hand with another condition called Mast cell activation syndrome. And that's a crazy syndrome, first described in 2011, where one of your white blood cells, called the mast cells, lives all over the body, and then in response to things that you eat or things you're exposed to, like hay fever or dogs, dander, whatever, your mast cells release these chemicals which cause rash, anaphylaxis, pain. There are literally 60 different symptoms that people with mast cell disease get. So you add those two together, and then you can have a full-blown case of POTS and mast cell disease, and these are the people who present to the doctors with brain fog, fatigue, and the doctor throws their hands up, and then the patient's left in the dark, and it's frustrating for the doctor because they've never heard of a patient with all these terrible symptoms, and yet you examine them, you look at them, and they look grossly okay until you start checking some basic things like their pulse. And so it's enlightening. In fact, Linda, you introduced me to a patient in Alaska, and we've been working together for the last year trying to get the right dose of LDN and working on other things such as small intestinal bacterial overgrowth. And she went from completely disabled to a person who's going to be known by many people who listen in or watch or go to the LDN conference.
Mm-hmm. And she's even doing the tango.
She's doing the tango, and she has gone through 16 years of being undiagnosed and seeing 19 doctors until she went to the Mayo Clinic to get her diagnosis, and yet continued to get substandard medical treatment until she looked up LDN, because it was her desire to find something natural to reduce autoimmune pain and inflammation.
So if there's anybody out there with the symptoms that you were describing, if they haven't had a diagnosis, how would they go about finding the right doctor to get that diagnosis? Where would they start to find the right person?
Well, first they could do something very simple on their own, and that's to lay down in bed and check their pulse after being in bed for 5 minutes, and then stand up and stand still for 10 minutes and check their pulse. If their pulse goes up 25, 30 beats per minute, then they would have to be very suspicious that they might have POTS. If they have these weird rashes or what we call urticaria and are undiagnosed, they have wheezing and asthma that's undiagnosed in terms of what's causing it, then they have to start thinking about mast cell problems. So in terms of finding the right doctor, well, I mean, if they could zero in and say, okay, I see that these are conditions and problems, and my stomach doesn't work. It's hard to swallow. My stomach fills up. I have nausea. I have bloating, irregular bowels. I can't eliminate because my sphincter is so tight that I just can't eliminate. That's POTS until proven otherwise. And so with the cardiac issues, then they want to find a cardiologist or a neurologist who deals with POTS, and a immunologist or an allergist who deals with mast cell disease. Or they could come to St. Louis. I'd be happy to see them.
So LDN and POTS, what kind of success have you seen with that so far?
Well, we're just getting started on it. I have 40 POTS patients that I've seen in the office. Some have found me through the support group. There's a local support group, and actually there are likely to be support groups elsewhere where they can get great referrals. And then some I've diagnosed just by being smarter, more or less, and less blind to the condition. So first of all, it's hard to blame your doctor too much. POTS was first described in 1993 and really kept to the cardiologists and only some, and to the neurologists and only some. And mast cell disease was first described in 2011. And so in view of diseases, if you will, that's not a lot, that's not a long time.
Mm.
So in terms of my own experience, I'm working on a publication for that, but our friend who's going to be at the Ldn conference, who we're writing a case report about her, did amazingly well and actually kept on improving by increasing her Ldn to 4.5. She started very gingerly until I got involved and encouraged her to increase it, but she still was a little ginger in her escalation of the dose. And ultimately, when she got up to 4.5, it really made a big difference.
This show is sponsored by specialists in gastroenterology who are located in St. Louis, Missouri, and they provide sensitive, reliable patient care. They diagnose and treat challenging GI problems. Dr. Leonard Weinstock researches extraintestinal disorders, including Restless Leg Syndrome, chronic pelvic pain, and rosacea. Visit www.gidoctor.net. The Ldn Research Trust is very proud of the Ldn book, which was launched at the Ldn 2016 conference in Orlando and has been a great success not only for the medical profession but for the patients wanting to learn more about low-dose naltrexone. Full details can be found on the homepage of the Ldn Research Trust. Discounts are available on bulk orders of the book, which is 10 or more. For details, email me, linda@ldnrt.org, telling me how many copies you wish and where you live. I will then be able to get Chelsea Green Publishing to contact you. (2017) special offer from Chelsea Green Publishing. Free shipping for US non-bookstore retailers on orders of 25 books or more. For full details, email me, linda@ldnrt.org.
But in terms of what I've seen so far, I'll give you, turning to my case report, not everybody has started the Ldn because many of them actually are on narcotics. So that's an issue in terms of getting out. But with respect to so I've treated 7 subsequent patients with Ldn, and 5 have noted benefits, including reducing pain, diarrhea, constipation, allergies, migraines, the orthostatic tachycardia, the rapid heart rate withstanding, and one of them actually had improvement with the mast cell symptoms. And then in a number of the patients, they have been treated with rifaximin, the antibiotic which I use for small intestinal bacterial overgrowth. And in 32 patients who took the breath test, 12 were abnormal. So a little over a third had an abnormal breath test. And 11 of those 12 were treated with rifaximin, and 9 had significant improvement of their GI symptoms. And the other 2 I'm actually waiting to call because it was just prescribed. So that's exciting because nobody's ever looked at small intestinal bacterial overgrowth before in POTS. And that's often not something that people in the neurology world or cardiology world know about.
Mm-hmm. Well, I mean, really amazing. You're going to be giving a short lecture on that at the conference, and you're going to be talking on a pre-recorded, because you have so much to share. You're going to be talking about inflammatory bowel disease, as well as celiac disease, and your POTS. And on the Saturday, you're going to be talking about SIBO. Now, from my own experience, I didn't know I'd got SIBO until you were pushing me to have a breath test. I just knew that I always had stomachache, which I learned to live with to a point. Having an uncomfortable stomach. How do people know whether it's, if you have problems with your bowels and your stomach feeling uncomfortable, how do you know whether it's irritable bowel syndrome or whether it's SIBO? Does the regular person know?
Excellent question. Excellent question. Well, first, I like to think of irritable bowel syndrome as a apple pie. And I'm going to take that apple pie and cut it into pieces and take those pieces out and label them: motility disturbance, depression, stress, brief anxiety-induced irritable bowel, SIBO. And SIBO, small intestinal bacterial overgrowth, is going to be at least 60% of that pie. And so when you're making, pie charts, if you will, you can start explaining to people, well, I think on the basis of these symptoms or this breath test, which is not perfect, and I can explain why, that your problems, your irritable bowel syndrome, are really caused by specific factors. So with a syndrome, you can have many, many different pathological and physiological abnormalities, but it's different than gallbladder disease. If you have gallstones and inflammation, you cut the gallbladder out, you're cured. That's a disease. You can't remove the intestine and expect to be cured of irritable bowel syndrome. And so in a way, that's not a disease. But that doesn't mean that there's nothing wrong. In fact, there's evidence for small intestinal bacterial overgrowth in probably 60% of patients with irritable bowel diarrhea. And many of those patients have an autoimmune antibody. So now there's a condition I call IBS autoimmune SIBO. And what happens is you get food poisoning, and then you get a toxin that enters the bloodstream from the bad bacteria. Your body acts upon that toxin and creates an antibody, and that particular antibody triggers an autoimmune antibody against one of the important nerves in your intestine. And with that antibody, you have damage to the nerves, so your small intestine doesn't contract well, and you build up bacteria in the small intestine. Now, in the colon, we have trillions and trillions of bacteria, but in the small intestine, we literally have thousands in the upper and maybe a million or so in the very end of the small intestine. But if we have too many bacteria in the small intestine, then every time we have scones or bread, whatever country you're from and what you like to eat, the carbs, you're going to feed your bacteria. And the bacteria are going to ferment it and create gases and distend the small intestine, and it'll get acidic, and that triggers diarrhea. But those bacteria also cling to the wall of the small intestine, releasing toxins and damage the small bowel lining. And that turns into a situation where patients develop extraintestinal conditions, such as rosacea, Restless Leg Syndrome, complex regional pain to some degree, but we also worry about interstitial cystitis and chronic prostatitis. And those are just to name a few. Fibromyalgia is a biggie, and chronic fatigue is a biggie. Other patients with irritable bowel, well, they've got a bad mix of bacteria in those trillions of bacteria in the colon, and that's a problem in terms of digesting foods, especially things that don't get absorbed well in the small intestine. So it feeds the colon bacteria, and then we get bloating and gas and discomfort and diarrhea. Or some of our bacteria produce methane, and that causes constipation. So it's complicated. I'm going to be giving actually a talk for about an hour on irritable bowel, and then getting a better understanding of small intestinal bacterial overgrowth, and showing how the thinking about irritable bowel has changed considerably over the last 4 decades.
And do people have the breath test only to diagnose SIBO?
So there's what we call invasive technique, namely a catheter is placed into the nose, or a scope goes down and you suck out fluid out of the first part of the small intestine, and you can culture it. But that's invasive, and culture is difficult because we've got 400 different types of bacteria in the gut. And then the indirect test would be breath testing. And the problems with breath testing is if that lactulose that you drink to sample the bacteria, and I'll explain that in a second, can rush through the small intestine quickly and get to the colon and give artificially high levels of gases. But what happens is lactulose is a sugar that's not absorbed. The bacteria gobble the sugar up and start fermenting it, and then the gas builds up in the small intestine, and we're able to measure at this time hydrogen and methane, although there's a prototype also for hydrogen sulfide, which can give a rotten egg smell. And that goes into the bloodstream. The bloodstream goes to the lungs. You breathe out the air, and then you measure the hydrogen or methane in your air that you breathe out. And if the breath shows that the hydrogen and methane show a very high level early on in the test, well, that suggested that you have too many bacteria in the small intestine.
Very clever, isn't it?
So that's when we diagnose, so that's how we can diagnose that condition.
Mm-hmm. Well, we'll just have a break and we'll be back in just a minute. This show is sponsored by specialists in gastroenterology who are located in St. Louis, Missouri, and they provide sensitive, reliable patient care. They diagnose and treat challenging GI problems. Dr. Leonard Weinstock researches extraintestinal disorders, including Restless Leg Syndrome, chronic pelvic pain, and rosacea. Visit www.gidoctor.net. The Ldn Health Tracker App, called My Ldn, is available free for Androids, iPhones, Macs, PCs, iPads and notebooks. The app allows you to keep track of all your medications, pain levels, sleep, quality of life, etc. You can print out graphs and charts to take to your doctor. Full details on the Ldn Research Trust website. You can keep a journal so you won't ever forget anything again, and set alarms. The app is free and all your information is held securely and anonymously. By using the app, You'll be taking part in the world's largest LDN survey, anonymously. Any questions, please email me, linda@ldnrt.org. Welcome back. I wondered if you could tell us a little bit about restless leg syndrome.
Restless leg syndrome. It is a fascinating problem. When I was in internal medicine for 13 years, I really didn't have too many people complaining about that. I think they underestimated it. And then the recognition of this condition increased. It wasn't clear how that happened, but once again, I think we can thank the drug companies for that. Just like people with acid reflux didn't really bother their doctors about it until the purple pill was there. When the drugs became available for restless leg syndrome, and these people used to go to their neurologist and complain, then with the television exposure to medications, people realized they could do something about this condition, which plagued their nighttime activities. So it is a fascinating condition. I'm going to just define it for everybody, but basically it's a compelling urge to move the leg. So it's not the kicking while you're sleeping. It is a response to some nocturnal event, which we can get into a little bit, that results in the compelling urge to move the legs that is associated with discomfort. And often people call it a creepy crawly feeling. Can be numbness, pins and needles. It could be just difficult to describe. And then it forces people to actually get up and walk around. And because when they do walk around, it gets better. So again, this is something that generally occurs with rest. It worsens at bedtime, and it's alleviated by movement as long as you're moving. And so people have that, utsy feeling that just have to move their legs. It's not the toe tappers, the people who are nervous or tapping their feet during class or whatever. And it's not the people who have sciatica, who have pain radiating down one leg and having to move their body around. So that's the basic criteria of how restless leg syndrome is defined. And it, as I said, is fascinating because it's linked up with 50 different diseases. First of all, there's one branch of it that we don't know what the cause is, idiopathic. There's familial restless leg syndrome with known genes that are linked to it. And then there's secondary restless leg syndrome, where many patients with many different diseases, and as I said, up to 50, will be associated with restless leg syndrome. So people who have renal failure or irritable bowel syndrome or small intestinal bacterial overgrowth syndromes, scleroderma, liver disease, pulmonary, the list goes on. I mean, there are categories that I can talk about, but there's something basic to all these conditions that has to make sense. And so I'm lucky enough to be collaborating with Dr. Arthur Walters in Vanderbilt, who has been researching this his entire life. And my interest started with irritable bowel syndrome and small intestinal bacterial overgrowth. And it was one of those light bulb moments, if you will. And you talked about, my interest in things and how I got interest. Well, I went to a meeting on rifaximin, the antibiotic that has been long used in Europe, 20 years before it was even introduced into America. And it was actually introduced for the treatment of traveler's diarrhea. But people, starting a few years earlier, one particular group at Cedars-Sinai in UCLA, were using it for irritable bowel syndrome and small intestinal bacterial overgrowth, and developing it in that area. They also looked at it in other conditions, and they started thinking about other conditions. But they basically made the point that irritable bowel syndrome was associated with bacterial overgrowth. And at the meeting, Dr. Pimentel said bacterial overgrowth was also associated with fibromyalgia. So I was reflecting on this, and he also introduced the idea of post-infectious irritable bowel syndrome, which we just talked about, namely developing an autoimmune antibody in response to bad infections. And so I was sitting there thinking about my cousin who I was treating, who had post-infectious irritable bowel syndrome and terrible restless leg syndrome. And so I studied, as soon as I got home, I studied fibromyalgia and found out that 20% of the fibro patients had restless leg syndrome. So I said, well, if IBS can cause by post-infectious irritable bowel with bacterial overgrowth, and fibro can have bacterial overgrowth, and fibro has restless leg syndrome, why not SIBO being associated with restless leg syndrome? So I called Steve. I said, okay, tell me about your RLS, restless leg syndrome. And he said, well, it started on the plane coming back from this trip where he got terribly ill with a diarrheal illness. And so he had post-infectious restless leg syndrome. And so that's what got me started on research that I've been doing for the last 12 years on restless leg syndrome and other conditions that have, again, one of those little light bulbs. Could this work for that? Could that work for that? So forth and so on. And that's what got me excited about research into the applications of small intestinal bacterial overgrowth. Now, Dr. Walters said, okay, that's interesting, but could it be additional? Could it be something else? Because I told him, we had a meeting, he gave a lecture at Washington U, and I came to talk with him after he talked, and he's an open-minded neurologist, which is possibly as rare a thing as rare can be. And he said, well, okay, well, could it be the inflammation, or could it be an immune reaction that's occurring, and that's why we have restless leg syndrome? So we did this review paper where we looked at all different diseases that were associated with restless leg syndrome and looked at those who had small intestinal bacterial overgrowth, iron deficiency, inflammation, or immune conditions, and basically came up with a hypothesis that it could be all of those things that are combining to result in restless leg syndrome. And then I introduced the idea of low-dose naltrexone to him, because there's a history of that, and I've been using it in restless leg syndrome therapy. And he got interested in it because he has studied lack of, basically one of his discoveries was lack of endorphins in the brain. So I said, Art, well, possibly why LDN works in restless leg syndrome is that we're increasing endorphin levels. And so now we have a whole great hypothesis how that works.
Well, I have to say, I used to have restless leg syndrome before I started LDN. And how it felt for me is when I got in bed and it happened every single night, my legs would feel uncomfortable, and I would try really hard not to move my legs. And of course, they used to thrash around a bit, move around, and then they would lie still. And then I would think, I need to move my legs. Well, I'm not going to move them anymore. I've moved them enough. I used to think, well, I'll move them just once more and then they'll stop. And it used to happen for quite a long while before I went to sleep. And having MS, I then used to have to wake up and go to the toilet. And of course, that would then upset my legs again. But luckily, since being on LDN, I don't have that problem. But it was, for me, it wasn't numbness or pins and needles. It was just uncomfortable, so uncomfortable. You had to move your legs. You didn't get a choice. They didn't move involuntary. I used to have to move them myself, but move them I had to, and that was very annoying come bedtime.
That's a great description. Well, that's a great description. I mean, it does go along. Restless leg syndrome has a comorbid disease where the legs jerk while you're sleeping and you kick your bed partner, but that's not restless leg syndrome. No. That's periodic motor limb disorder.
No, I knew I was moving them, but I didn't have a choice. I had to move them. Now, I know that people listening to this, we have many listeners who have fibromyalgia, and they're probably thinking now, I've got fibromyalgia, I have restless legs, I must have SIBO. If they are tested and they have SIBO, and if they're LDN users or not, the LDN hopefully would help with all of those things and with their restless legs. Would treating the SIBO make a big difference to the fibromyalgia, pain and sleep problems and the fibrofog, etc., etc.?
Oh, absolutely. Absolutely. There are many things going on in fibromyalgia, but a big one is SIBO. There's some inkling that there might be a disarray of bacteria or what we call dysbiosis in the colon, but that's hard to treat. But SIBO, small intestinal bacterial overgrowth, is relatively easy to treat. And the fact is, in my patients who have what we call idiopathic or primary restless leg syndrome, 69% had SIBO versus 11% of controls. And remember, I said that the breath test is not perfect, and it was 11% false positive. But many of our patients did not have GI symptoms, and they had restless leg syndrome. And that said, many patients with fibromyalgia don't necessarily have too much GI symptoms, but, I think, if I may say so, you've been living with some GI symptoms that you've just gotten used to.
Yes.
And recent treatment has resulted in a major change, right?
That's right, yes.
So the fact is that we can have small intestinal bacterial overgrowth and suffer in other ways. And so I have a group of men who have type 3 chronic prostatitis. They have pain in the perineal area, in the in the testicles or in the penis, or pain with intercourse, and they may or may not have SIBO, or they may or may not have SIBO, or they may not have GI symptoms. But if they have SIBO and they're treated for that plus LDN, they do well. And same thing for women with interstitial cystitis. On the flip side, we have a lot of patients with irritable bowel who have interstitial cystitis, and there's some mast cell disease in irritable bowel syndrome, which probably plays a role into interstitial cystitis. And yet, I'm finding some of my patients who have mast cell disease do respond to low-dose naltrexone.
Well, we've learned so much. really, really interesting. We'll have to have you back on another show. Our time is just about up. But thank you very much. It's been amazing. Now, I know there will be people that would want to ask questions. If they emailed me, would you have the time to answer some questions?
Absolutely. So
Okay.
if we get a bunch of questions together and we group them into lumps and categories, that makes it easy.
Fantastic. So if anybody would like to ask Dr. Leonard Weinstock some questions related to what's been discussed today, restless legs, fibromyalgia, SIBO, can't remember what else we discussed there, POTS.
Irritable bowel.
An irritable bowel.
POTS.
Exactly.
Mast cell disease. Yeah.
So if you would like
We
to...
discussed a lot.
We have. If you'd like to email me, Linda, LINDA, ldnrt@gmail.com. We'll put all those emails together and we'll send them to Dr. Leonard Weinstock, who will put together some Q&A questions. That will be very interesting. Thank you very much for joining us today.
Thank you, Linda.
This show is sponsored by specialists in gastroenterology who are located in St. Louis, Missouri, and they provide sensitive, reliable patient care. They diagnose and treat challenging GI problems. Dr. Leonard Weinstock researches extraintestinal disorders, including Restless Leg Syndrome, chronic pelvic pain, and rosacea. Visit www.gidoctor.net. The Ldn 2017 conference will be held in Portland, Oregon, in the US, 22nd to the 24th of September. If you are unable to attend in person, we'll bring the conference to you, regardless where you live. You can participate via our live stream. Check out www.ldn2017.com for early bird discounts. The conference will examine life-changing breakthroughs for treating multiple sclerosis, Crohn's disease, colitis, autism, irritable bowel syndrome, lupus, fibromyalgia, rheumatoid arthritis, chronic pain, mental health issues, restless leg syndrome, and many other conditions using low-dose Naltrexone. For tickets, live stream, and sponsorship opportunities, go to www.ldn2017.com. The Ldn Research Trust was established as a registered charity in 2004 in the UK. We have members in most countries around the world, with approximately 52% in the US. Our aim is to spread awareness of LDN in hope that one day it will be prescribed as a first-line treatment. We have our mailing list, website, forum, Vimeo channel, Facebook pages and groups, Twitter, LinkedIn, newsletters, conferences, LDN documentaries, the LDN app, the LDN book, and now the LDN radio show. We are supported by a team of LDN experts who are our medical and pharmacological advisors. The charity relies totally on donations and is operated by volunteers. We hope for an LDN and MS trial soon, and we help and support doctors and researchers who are planning trials. Please visit our website. The Ldn Research Trust Facebook group has almost 18,000 members around the world. It is a great place to start your research and connect with others. www.facebook.com/groups/LDNRT. It is a closed group and only members can see your post. Nothing is shown on your page or feeds. Posts can't be shared. We do also have a page where you can share links. It's www.facebook.com/LDNRT. Check out our books, conference pages, by searching on Facebook. The Ldn Research Trust also has a Twitter account, and you can find us on twitter.com/LDNR Trust. The Ldn Research Trust has an Ldn Vimeo channel. I have interviewed over 550 Ldn prescribers, researchers, pharmacists and patients from around the world for many conditions. You can find the link on the Ldn Research Trust website. If you'd like to be interviewed sharing your experience, please email me, linda@ldnrt.org. I look forward to hearing from you. The Ldn Research Trust has its own forum, which can be found at forum.ldnresearchtrust.org or via our website. The forum is divided into sections, so it's easy to navigate and find what you're looking for. You can share your experience, ask questions, keep a journal, etc. Unlike Facebook, the posts are always easy to find and don't get buried. We have a private medical professionals only section. To find out more, please email me, linda@ldnrt.org. Any questions or comments you may have, please email me, linda, Linda, @ldnrt.org. I look forward to hearing from you. Thank you for joining us today. We really appreciated your company. Until next time, stay safe and keep well.